So, as we just discussed, skin tumors of the face or the scalp require surgical excision. Now, this surgical excision has to be balanced to avoid damage to critical aesthetic units. If we follow 1 centimeter margin for squamous cell carcinoma, and if it is in the eyelid, you know you're going to use vital cutaneous structures. One of the ways to minimize this loss of critical aesthetic units is to have in some way an intraoperative assessment of margins, whereby if you can have an intraoperative frozen section assessment of the peripheral as well as the deep margins, we can resect with slightly narrower margins and we can give the patient a better functional outcome. So this is where Mohs has become very big in dermatological surgery. So what is the pitfall in conventional histopathological assessment? So in a conventional histopathological assessment, we do something called bread loafing of the tumor. Just like how bread is being sliced in vertical fashion, usually the tumors are bread loafed. And if you look at this picture, you've taken an elliptical excision of the tumor with wide margins. There is no tumor seen in section C, but this tumor is being extending into section C because it has got a deeper extension there. But when you breadloaf this tumor, the section C shows false negative margins, and you have left behind tumor that was hiding inside the deeper parts of the bed where section C was bread loaf from. So conventional bread loafing only allows you to sample to a maximum of 10% of the tumor margins. We can't sample more tumor margin. So vertical sectioning cannot capture the true peripheral extension or the deep extension of the tumor, and we have false negative reports. So what we need is a rapid assessment of the complete peripheral margin and the complete deep margin. And this is where Mohs comes into play. Mohs, he was a general surgeon who developed this technique in the 1930s. He had done hundreds of cases and tried to present it in surgical conferences, but he wasn't given an opportunity. Finally, he had presented it in a dermatological conference and it was rapidly adopted. There is an American College of Mohs Surgery. There are fellowships for 1 year fellowships for Mohs Surgery. So, what Mohs achieved in his technique was there was complete microscopic controlled excisions. That is, he was able to excise the tumor with on table control and further excisions if the margin was positive or not. So, what are the indications for Mohs? So, if you have a recurrent tumor, as we saw in the NCCN guidelines, aggressive tumor subtypes like SCCs, tumors in high risk locations, tumors with perineural spread, tumors with poorly defined clinical margins, tumors arising in irradiated skin, and patients who are immunosuppressed. So, this is just the basic gist of the procedure. I'll show you some better pictures, the better text after this. What Mohs allows you to do is that you compartmentalize your excision and then you take horizontal sections of each compartment that you have taken, and you start that from the base of your excision, and then you put this in the cryostat and take horizontal cuts, and what you get in the horizontal cut is a complete peripheral assessment. And when you place this in the cryostat, when you place this to get the sections, you have to press the deep margin to the superficial margin. You have to compress the specimen. So the deep margin also comes in the same horizontal slice that we have taken. So if one of the quadrants shows tumor, which is marked by an ink, you go back and you excise that quadrant, and then you don't have to excise the other quadrants. Only that quadrant needs to be excised for tumor control. So it is excellent technique for both the peripheral as well as the deep margin. So when Mohs did this originally, he used a tissue fixative technique. So in tissue fixative technique, what happens? The patient will come to the clinic and the patient will be painted with zinc chloride. And this zinc chloride is left on the patient for 24 hours. So what did the zinc chloride do? It was very good for in situ histological preservation. It penetrated the tissue in a controlled manner. It was non-toxic and odorless. And once the surgery was done, it always left a very good bed of granulation tissue once the necrotic tissue sloughed out. And it was a compound paste containing these two substances. And based on the thickness of the zinc chloride you apply, the penetration used to change. So that is also in our control. So if you had a thick tumor, you apply more zinc paste so that more deeper sections of the skin are stained. So this is before the surgery. The patient is painted with zinc chloride, left for 24 hours, and then asked to come back to the operation. So what will the original chemosurgery process was? You first apply a keratolytic to the tumor. The skin will turn white and also allow the penetration of zinc chloride. Application of zinc chloride is done next with the thickness that you need for penetration. You close the area with a dressing, moisture tight dressing. The next day, the patient comes back to you. You excise the tumor, then you make it into quadrants or you make it into different zones. You orient the tumor, and then because the fixative is already applied, this is a fixative. You examine the lesion under the microscope. If any tumor was seen in any of the quadrants, you would go back and excise the second layer of tissue the following day. And then you keep doing this till the tumor was completely excised, and the defects were always used, mostly left to heal by second intention. So you understand the problem. Zinc chloride application has to be done prior. It requires multiple day settings for multiple excisions to ensure negative margins. The reconstruction was also delayed, and it was painful for the patient. And so these were some of the reasons why the chemosurgery, that is the tissue fix surgery, gave way to the more modern technique of the cryostat being used. And it was one of his students who actually propagated the cryostat technique. So how do you do it? How is modern Mohs done? So first you outline the tumor, you give local anesthetic, and you debulk the tumor till you can see the skin margins. Once the skin margins are visualized, you make etch marks around the lesion, 3 o'clock, 6 o'clock, 9 o'clock, at 12 o'clock, and so that you know you have some orientation for mounting the specimen. And then you take a thin margin of tissue circumferentially, and then you go at an angle of 30 to 45 degrees towards the base of the lesion, and you excise the lesion. Once the lesion is excised, it is cut into halves or quadrants, and then you mark it with color coding, and then you press the lesion so that the deep margin comes to the same plane as the epidermal edge. And only if you bevel the cut will you be able to press this and do this flattening process. And then you cut the tissue in a horizontal section so that the peripheral and deep margins can be assessed. And this is done using a cryostat and frozen section compared to the traditional bread loafing, which is vertical. If you have any residual tumor under the microscope, then whatever mapping you have done, you go back to that quadrant and you remove the next layer of tissue and you repeat the process. And once you have a tumor free area, then the patient is considered free of tumor. And usually you take about 1.7 to 3 stages per tumor to clear this thing. And this number of repeated frozen sections and cuts may be higher if the tumor is much more or much larger or in complicated redo cases. So the key here is to make the etch marks on this, is to debulk first, see the skin margins, mark the edge marks on the 4 quadrants, and it is to use the blade at a beveled angle of 30 to 45 degrees, then to flatten the lesion, the specimen onto the cryostat so that the deep margin comes to the plane of the epidermal peripheries. Then the frozen section is done. Usually for squamous cell carcinoma and most of the other carcinomas, hematoxylin and eosin staining is adequate. If it's a basal cell carcinoma, sometimes they use toluidine blue, but this is how the specimen is read. Patient has to wait for an hour and a half. So, and once they have been decided that there is no more tumor, the patient can have the reconstruction procedure done. So, the advantages are there are multiple papers, publications, reviews that have looked at the cure rates for Mohs, and this is very high cure rates. Even compared to larger resections with larger margins, Mohs has comparable cure rates, and it's very high for high risk patients and recurrent tumors. It's an outpatient procedure. It is cost effective because in America usually the dermal surgeon reads their own pathology, and it's done as an OPD procedure under local anesthesia. So, and they just have a technician who works with the cryostat to give them the tissue slices. So, it's very cost effective from an American insurance point of view. We have complete margin control with minimum tissue loss. So, maximal preservation of uninvolved tissue is available, and we also are able to perform reconstruction once we are sure that there is complete margin control. Unlike in patients who are given the final histopathology, that too with improper peripheral margin assessment. So, in many ways, Mohs is the more suitable of the surgical procedures and histological assessments compared to the traditional techniques of bread loafing and final histopathology. So this is just a short presentation on Mohs. Any questions, I'll be happy to take them now.
Deepak, very nice presentation, Deepak. Regarding Mohs microsurgery, is it currently being done anywhere in India, or we don't normally do it?
No, they don't, sir. I don't think it is. Because you need to have a dedicated dermatopathologist uh, who is trained to be dermatopathologist, and you need to have a sympathetic pathology technician who can operate the cryostat. So I think we don't get that many early SCCs where aggressive resections are not required. So, but it will be useful for the user technicians.
So you were talking though that by beveling the knife, you would be able to get, and by the compression, you would be able to get the deeper tissue to the surface. How is that possible?
So for us, our aim is to make a slice which is horizontal, which will get us both the deep margin and the peripheral margin. So, and what you do is you compress this against usually it's mounted on a wood chuck. You compress it against that, and you take the slice from the deepest part of your specimen.
Okay.
So what will happen is when this is compressed to the superficial portions, you'll have both the deep margin in that section as well as the peripheral margin. Do you understand?
Okay.
Otherwise,
Okay.
deep margin will be in slice one, and your peripheral margin, as you keep going, your peripheral margin will come in section five.
Okay.
So
Okay.
you want
Correct.
both sections to come in one
Uh,
slice.
the thing is that the peripheral margin would go to the deeper surface, and then you're taking the deeper slice so that you
Correct.
get the
The
deeper margin and the
sections have
peripheral.
to start with the deeper slice only, sir,
Okay.
because that is the depth of our excision. And once you compress, the superficial spread pattern also will lay down.
Correct. 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 Right. Thank you very much, Lisa. Dr. Lakshmi? Hello?
Thank you, Deepak.
Yeah.
Deepak, you have nicely covered all aspects, and
Thank you, ma'am.
folks also explained very well. It is sometimes they will ask in exam.
Yes,
So explained very well with the diagrams and all.
yes, ma'am.
Uh, uh, I think there are no questions, so they understood it.
Like I said,
Yeah, Deepak, these two topics now that you have actually taken up today, both
yes,
these topics are important topics. One, in the sense that practically it is very important, the first one,
yes,
and always a lot of discussions would happen because it's very common for us to get headache or other area skin malignancies. So
yes,
in that regard, it is very important, and for the practical purpose, because a lot of cases also would be there. And
yes,
most microsurgery is again one thing that is important because of your Australian experience and other understanding of this particular topic. You would have seen that. Whereas we have in India, we hardly get to see most microsurgery.
yes,
So I think there also you have actually made it very lucid for all of us to understand and for people to actually write the theory part, because for some reason most microsurgery is a favorite theory topic
yeah.
for our exams also. So
Okay.
thank you very much, Deepak, for making it very
Melanoma is
lucid.
another topic, sir. Melanoma needs 1 hour,
Yeah,
more than
yeah.
1 hour, because
I am sure that we will find time in coming weeks, one of the weeks, where you will be able to talk on telecom
Because
for a
there's a lot
full
of
full hour.
questions and all those things, as I said.
Yeah. Okay.
So, thank you very much, sir. Thank you very much, ma'am.
Thank you.